And Greg, talk to us. What do you mean when you say cardiogenic shock? A lot of definitions out there. How are you defining it as an entry point in this
Yeah,
trial?
that's a great question. So you certainly can define it with lactate levels and hemodynamic measures and cardiac power output being below certain levels, et cetera. But we need a practical point of care definition for cardiogenic shock. So we're basically using a simple definition that is a patient presenting with an ST segment elevation myocardial infarction with a systolic blood pressure less than 90 millimeters of mercury for at least 30 minutes, no secondary correctable causes, and or requiring immediate substantial dose pressors to support the circulation, and evidence of impaired or decreased systemic perfusion, such as altered mental status or cool extremities. So a relatively simple definition.
Now, you mentioned pressors and the balloon pump in the other arm. Can people get pressors over in the Impella arm?
They can, and they certainly will early on, but the goal will be to try to wean pressors as fast as possible in the Impella arm to try to not whip the heart, because pressors obviously can increase arterial oxygen demand, increase afterload, et cetera, and we would rather rest the heart to decrease infarct size, and there's a lot of experimental evidence for that. So we'll taper the pressors and the inotropes as soon as possible as hemodynamics allow.
And is this all-cause mortality or cardiovascular mortality? Because again, with the large bore device, you could have some vascular complications that might cause someone to die. So which one is it?
Yeah, it's all-cause mortality, and we thought that is the appropriate endpoint. Within 30 days, it'll certainly be almost all cardiovascular mortality.
Sure.
But we do believe that complications should be included in the mortality endpoint.
Exactly. Well, Greg, when do you think you're going to wrap this up? How long do you think it's going to take?
Well, there's a lot of challenges to enrolling cardiogenic shock patients, and this is worth talking about because a lot of these patients are not compos mentis, and a lot of them present without a legal authorized representative, an LAR, in tow. And so how do you consent these patients? In Europe, there are standard pathways in many countries where they can be entered into a clinical trial such as this if they are in such a hemodynamic extremis and then be consented later. But in the United States, that pathway doesn't exist. However, there is a pathway called EFIC in the United States, an FDA regulatory pathway called exemption from informed consent, which basically states that you can consent patients for a randomized trial such as RECOVER-4 if the patient is unable to provide informed consent and there is no legally authorized representative available. But this has to be an IRB approved process, and it also has to be a community approved process. So you have to post it in churches and other areas that you're going to be doing this in the community. You have to have town hall meetings to have discussions about this, because we certainly want to go through all the appropriate pathways so there's no experimentation being done. And there's any concerns about that in the community. So it's actually a laborious process. It takes about 6 months to get EFIC approved in most communities. But that's going to be a very integral part of this protocol, because we'd imagine that 50 to 70% of patients could get consented under EFIC.
Yeah, we're using EFIC in a trial that I'm doing, which is a pre-hospital therapy trial of about 2,500 patients. You're right, Greg, it takes a long time, but then we're providing a full consent, later after the procedure is done. We are seeing some people withdraw consent, not many, but it's a possibility that a few people may withdraw consent as well. So it's a complicated process.
It is a complicated process. I mean, at least this is with 2 FDA approved and indicated devices for this procedure in this setting. So we don't expect too much withdrawal of consent, but that certainly could be the case in a few patients. So let me also mention that this trial is sponsored by Abiomed, but they've let us run it as really an academic driven trial. And we've really put all the bells and whistles into this study to do it right. There'll be a longitudinal assessment of left ventricular function, quality of life, cost effectiveness, everything you can imagine, serial lactate levels, et cetera. I'm honored to be the study chair of the trial. Bill O'Neill and Naveen Kapoor are the co-principal investigators of the trial. It's also been designed with an amazing committee with Dan Burkhoff and Jacob Moeller, who's the PI of Danger, and Neil Dicker and others from the ethics side. So it's taken a long time to get a trial like this to this point. And there's so much talk on social media, and we're hoping that you're going to be able to help us, because there's so much criticism. People either so strongly for or against the device that's being used in this investigation, that, as I wrote in a recent Twitter post, we need people to stop yammering and start randomizing. And we really need the support of the academic community, because I think any true scientist and clinician that takes care of patients can objectively say, we don't have the answer. There is equipoise for this question.
There truly is equipoise. Big, important question, very big unmet need, high mortality. Stop yapping, start randomizing. I agree with you, Greg. Thanks for leading the charge to get a credible answer to this very important question. Thanks for joining us today.